I'm very pleased to introduce Lori Mayer. She's the Director of Medical Research Services for the MS Clinic of Central Texas in the Austin area. She's an MS certified nurse and a member of the Board of Directors of the International Organization of MS Nurses. She's been co-chair of the town hall discussions with the MSCN, promoting the sharing of information with nurses involved in treating MS patients. Lori is committed to enhancing the role of nursing in the care of MS patients and empowering the nurse through education and expansion of nursing research. And Lori is currently working on her Doctor's of Nursing Practice, PhD, so that's great. All right, Lori.
Thank you, Dr. Creedy. Can you all hear me pretty well? Okay, all right, good. It's very daunting for me to follow two such wonderful scientific presentations that we've had this morning. So we're going to switch our gears a little bit and move into a little bit more of psychosocial issues. All right. So this talk is basically strategies to identify and address barriers to patients' adherence to MS therapies, which pretty much, there's my disclosures, and our objectives as far as that's concerned. What we're really trying to do today is we're really trying to identify the strategies in particular to overcome barriers to adherence to MS therapies. And we're going to discuss really how to incorporate these strategies into clinical practice. So we want to improve our patient outcomes. This is actually a very profound quote, and it's very famous. It's from C. Everett Koop, who was the 13th, I believe, the 13th Surgeon General of the United States. Drugs don't work in patients who do not take them. And I think that the World Health Organization would definitely agree with him. And looking at in their report, actually back in 2003, they referenced statistics to the chronic diseases that they have listed here. And their stance was that poor adherence to treatment of chronic diseases is a worldwide problem of striking magnitude. I'm sure when the WHO, at this point had no idea what an understatement this would become. So their definition of adherence is not taking the medication as prescribed, taking either too little, too much, for too short, too long a time, at the wrong time, very ineffective way. And we know it can have negative consequences for the patient's health as well as for the economy. Non-adherence is associated, and we will talk about some of the clinical trials, with reduced treatment benefits. And it can really obscure a clinician's assessment when they're looking at assessing the therapeutic effectiveness of a medication. About 30 to 50% of treatment failures is actually thought to be due to adherence. All right, this is a very interesting study. This information is from the National Association of Chain Drug Stores. And these recent statistics, these were basically in 2010, were based on data from IMS, and IMS is a global company that provides information, services, technology to the healthcare industry. This slide really does give us a visual of the statistics. And what they were looking at were 100 oral antihypertensive prescriptions, medication, of an oral medication. For every 100 written prescriptions, okay, which we've got in our little medicine cup right here, about 50 to 70% actually go to the pharmacy to be filled. And of those, we've got about 48 to 66 that actually come out of the pharmacy. And 25 to 30 of those are taken properly, and our end result is 15 to 20 are actually refilled as prescribed, which is a very, very low percentage. So really, when you're thinking about it, about 20 to 50% of all patients are non-adherent to the therapies. This is a study actually done by Wong and al., and it was up in Canada. And what they were doing, they were evaluating MS patients in Ontario, and they were on the injectable medications. So we're looking at interferon beta 1A, IM, some Q, interferon beta 1B, and glutamate acetate. All right. So this was pretty much a retrospective study. Newly treated patients were followed until they discontinued treatment or they actually switched to another disease-modifying therapy, or for up to 2 years, whichever actually came first. And when they were looking at the cumulative persistent rates, and you're looking at the downward slope that we see there, all 4 of the disease-modifying therapies were very similar over time. So after 2 years, the proportion of patients who had actually discontinued or switched to another disease-modifying therapy was similar across all 4. And so conclusion to this, when we're looking to adherence to the disease-modifying therapies in these adult patients in Ontario, it was actually very poor, which was pretty much consistent with previously reported adherence rates that they had in Canada. So how does adherence impact our MS outcomes? All right. Burks and al., actually, they presented this information. This was at a posters at ECTRIMS in Lyon this past October. And despite the proven benefits of injectable therapies for patients, more than 40% of the patients who had received an MS diagnosis in this study were actually not being treated. So the statistics evaluated were looking at relapse rate, hospitalization, and they were also looking at their medical costs. And this was over a 12-month period with a 12-month follow-up. So the results were what was expected, that on an average, patients, those that were adherent to therapy, had lower relapse rates, lower hospitalizations, and lower medical costs. And so really when you're comparing them to the non-adherence patients as well as the discontinued therapy patients, we know that this supports the importance of being on a disease-modifying therapy. And adherence, we want to optimize those patient outcomes, and we do want to minimize resource utilization. We need to be cost-effective. Well, actually, the WHO identified 5 factors which they considered dimensions of adherence. And we know that patients' adherence to medications regimen is directly related to good patient outcomes. Central factor that's key to adherence is that provider-patient relationship. The discussions help the patient understand their illness as well as the risks and the benefits of the medications. And it is a daunting task when you have so many different medications that you want to discuss with the patient, and we usually narrow them down to a few that we might feel might be appropriate for them. So considering adherence and social and economic factors, okay, it depends upon what type of family. What type of social network does the patient have? What type of access do they have to the facilities? What about cost? What about medication costs? Okay. Looking at the medical condition-related factors, does this patient have any chronic condition, any comorbidities that would complicate their treatment? Looking at therapy-related factors, is the patient experiencing side effects of therapy? Are they having difficulty mastering certain techniques, such as self-injecting? How are they actually perceiving the immediate benefit of the therapy? Are their expectations actually realistic? Are there any social stigmas associated with the medications? The 5th factor is patient behaviors, which encompasses visual impairment, cognitive impairment, maybe some impaired mobility or dexterity issues. So really when it comes down to all 5 of them, the most important relationship actually is that provider-patient relationship. So we're going to look at some predictors of adherence. Okay. Self-efficacy. This is really how the patient measures their own ability to complete tasks and to reach their goals. And, by determining the beliefs that actually the person holds regarding their own power to affect situations, it really influences both the power of a person actually has to face challenges competently and the choices that a person is most likely to make. So these effects we know are apparent and very compelling with regards to health behaviors. Hope is another predictor. This is a quote that I did get permission from Robert Brault, who's a writer, which I thought was very intriguing. If you knew that hope and despair were paths to the same destination, which would you choose? And it's something to think about. It's something to think about that we, as providers, need to understand the perspective that the patient is coming from. How do they perceive their support? Do they have confidence? Is there a mutual respect between provider and patient? Has the patient previously been on a disease-modifying therapy? There's a big difference when you're comparing a patient who's just started a disease-modifying therapy to one who has tried several over time. Spousal support. Do they have family support? The perceived benefits of adherence. How do they perceive it? Injection devices, we know that those have been actually very positively influenced adherence in our patients. So looking at some predictors of non-adherence, we actually have more of these than we do have predictors, and we'll just touch on a few of these. We'll highlight a few. Patients' literacy level, okay, and their primary language, we need to make sure that they understand the information, that we are providing for the patient. Depression, we'll touch on that, effects of depression in just a little bit. Cognitive impairment, is the patient just forgetful? Is this an issue they have to deal with? Do they have memory issues? Does the patient have a good understanding of MS? Okay, do they believe in the benefit of the treatment? Additional predictors, maybe somehow some patients believe medications are harmful. Some do. Maybe they're tired of taking them, shot fatigue. This is something that we've been dealing with very recently. Are they inconvenient? There may be the fear of side effects. All right. In addition, there are cost barriers to the access of care, which may be one reason why patients maybe miss their appointments. So Treadaway et al., they had an online survey, and this was interesting. There were 798 patients, and 17 clinics who responded to what were the reasons for missing a dose. Okay, so the aim was to identify what factors actually most influence the non-adherent behavior with the disease-modifying therapies that were available. And again, these are the 4 platform therapies that we were talking about. So the non-adherence rates for all the patients, and this is across all therapies, was about 38%. It was very similar. Most common reason that the participants listed for missing the injections was they simply forgot to administer it. 58%. Other factors they looked at injection site reactions, they looked at the quality of life of the patient's perceptions, on the injectable medications, hope, depression. These are all support things that were assessed in relationship to the adherence. So as far as barriers, we need to be able to identify the barriers to adherence. So forgetting the medication, one issue. Some have injection anxiety. Maybe they don't believe, again, in the efficacy of the medication. Maybe they're having intolerable side effects, injection site reaction, or some other side effects that they're dealing with, and they're having a very difficult time actually coping with them. Okay? Many patients become complacent and fatigue. That's another barrier. Or maybe a barrier is directly related to a specific disease symptom, such as impaired visual function or manual dexterity. So these are all different barriers that we really need to identify. So as far as uncovering them, what do we need to do really as providers to avoid the barriers? And this is a triangle of two-way streets. It's the patient, the provider, and the healthcare system. And we all actually really need to communicate with each other. As a provider, we need to have a really good understanding on how the healthcare system works, the insurance costs and the formularies, as well as helping the patient understand the disease process and the goals of therapy. What are our goals? They need to know the proper use of the medication. In addition, the patient needs to have a really good understanding on how to navigate the healthcare system also. They may have issues with access to medical care. There may be an issue with cost. Okay, has there been any changes in their formulae? You know, and actually with the Affordable Care Act that's coming up, there's going to be some interesting changes when the patient needs to go to the marketplace to purchase the insurance. So let's talk about some strategies that we can use to actually promote adherence. Some of our patients really have unrealistic expectations, and we need to acknowledge that relapses still occur. We don't have a cure, but we know we can slow the progression of the disease. We need to emphasize that these relapses might be more frequent or actually more severe if the patient is not on therapy. And we need to remind them, in addition, that even though they may not be experiencing any symptoms, there's still subclinical disease that actually is going on. If the patient's needle phobic, we need to educate them on injection technique. And we found most recently, we've been retraining. We found the retraining of patients who have actually been on the injectable therapies for a long period of time is actually very advantageous. And the feedback that we've actually gotten from the patients has been extremely positive, because I think they get a little bit complacent, sometimes maybe a little bit, their technique gets a little sloppy. And they actually really appreciated the fact that we sent a nurse out there to re-educate them on that. So some strategies to promote adherence, treatment fatigue. You know, we really need to reinforce the importance of therapy for maintaining their health and quality of life. We may need to address the specific symptoms, you know, with fatigue. Maybe we need to readjust their injection schedule. There may be pharmacological interventions that we would like to discuss, as far as non-pharmacological interventions, which could be very beneficial. So we really need to look at all three of those. Cognitive deficits, reminders. So many of us need reminders, and I'm in that group. Constant reminders where I put on my phone so I can remember things. I usually miss teleconferences. That's probably the one thing I miss the most. They may have had insurance changes, just as we had the first year, or change in financial status. And this is where the patient assistance programs have been so extremely helpful to us as MS centers, because I know that I can refer them to those programs if they're having issues. However, I need to know they're having issues. So those patients, they need to call, they need to let us know, and then we'll refer them. So as far as looking at oral and injectable medications and the impact on adherence, we're hoping that with the phase 4 studies with the new orals that have come on the market, that we will see shortly, you know, some information on adherence on the oral medications. We know they might be more comfortable emotionally for the patient, more convenient, convenient dosing, less visible reminder of the disease. There's definitely no specific training in particular. However, they need to be, the discussion on how to take medication needs to take place. We might see some possible improved tolerability. I think we'll have to wait and see on some of that. So as far as patient preferences, this is a study. This was actually presented at ECTRIMS in Lyon again, and we were looking at the patient preferences of the disease-modifying therapies. These were 50 adults. They had relapsing remitting MS, and what they did was a card sort strategy, and they were assessing preferences. So they actually rated 18 hypothetical profile cards, and they rated them from 0 to 10. And the stronger preferences that came out for preventing long-term disability, that to them, preventing the long-term disability progression was actually more important than preventing the relapses. So the top two that they were interested is preventing long-term disability, and in addition to the MRI changes that they had. The daily oral administration was actually preferred over the injection in that study. So as far as addressing, you know, assessing adherence, we need to do this at every visit. You know, as nurses, we see the follow-up patients. And I think at every single visit, we need to recognize that the patient's tolerability and adherence can be very challenging for them. So some of the questions, and actually the best tool that we have for communicating with the patient is just asking questions. And at times it can be the best assessment tool that we have for assessing tolerability. So tell me about your daily schedule. How do you take your medications? Can you show me the last 3 injection sites? Very important to ask the patient to see them. You ask them, how are your injections doing? Everybody always says fine. But by asking them to see the injections, it gives you a good visual of what they're actually really dealing with. Let's see, how many times did you miss a dose in the last week, in the last month? Quantify it by time. Do you use a pill box or do you use an organizer? How do you pay for your medications? Maybe we would like to explore some options for reducing the medication expenses. And this is, again, where the patient support programs actually are very, very helpful to us. We'll refer the patient to the patient assistance programs. If possible, would you like me to simplify your medication regimen? Those are things that we can talk about. And it may be just changing the time of taking the medication that actually might improve the adherence that we're dealing with. So depression and adherence, we're just going to touch on this pretty quickly. Depressed patients are 3 times more likely to be non-adherent. So it's really important that we assess whether or not the patient is dealing with depressed or what level of depression the patient's experiencing. This is looking at the impact of comorbid depression on adherence to therapy for MS. And really the conclusion was that MS patients with comorbid depression were approximately half as likely to be adherent to their disease-modifying therapies, relative when you're looking at patients without depression. So the treatment with the antidepressant for at least 6 months was associated with a better adherence of therapy. Extremely important for that to be assessed when the patient comes in. So MS nurse adherence management, very challenging for us. It's ongoing and can be very complicated, and even more complicated now, that we are getting more medications out there. We need to include pharmacological as well as the non-pharmacological strategies in the symptom management. And we need to encourage behavioral interventions, include exercise, stress management, patient education, psychotherapy. It's a multidisciplinary approach that we're dealing with. So each of these approaches really, in the end, can affect the psychosocial outcome measures, the quality of life, the fatigue, and the depression that the patient has to deal with. So strategies: improve adherence, simplify the regimen, and actually here are just some suggestions as far as using the word simplify. So we're going to simplify it. Maybe as simple as changing the time of day to take the medication, as I mentioned earlier. Tell me about all the pills you take. Maybe we can determine together that we could take them all in the morning, or how this is going to work. Maybe we need to take it breakfast and lunch, or breakfast and dinner, and associate it with a meal. So that what we're doing is actually matching the activity or the taking the pill to activities of daily living. Imparting knowledge. Allow the patient to repeat back the instructions. Very important, especially in their own word. Here's the prescription. I'd like you to take 2 pills twice a day, depending on what it is. So how will you, as a patient, how will you incorporate these medications into your daily routine? It's important to do that as far as their routine is concerned. There may be some family members maybe we need to evolve. Maybe your wife can help you remember to take the medications, or use certain reminders on your phone. We need to look at the costs. It's important for them to take the medication every single day if it's prescribed. However, if the cost is a financial hardship, we really need to know right away, and then we will look at different solutions. Case 1. This is a 32-year-old woman, presents with optic neuritis. Her visual acuity is 2400, right eye, 20/20, left eye. without visualized abnormalities on the fundoscopic exam. Neurologic examination was otherwise unremarkable, and laboratory studies were within normal limits. The MRI brain revealed 8 T2 lesions, including periventricular and juxtacortical lesions. 2 GAD-enhancing lesions were identified, and 1 on the right optic nerve. The other in the posterior left periventricular region. So after a discussion with this patient, it was decided not to pursue a lumbar puncture due to the patient's fear of the test, which we do run into this quite often. Discussions were initiated about the diagnosis of multiple sclerosis based on the CIS and the MRI's findings. A card showing the McDonald's 2010 criteria was shown to the patient and used to explain the concept of dissemination in space and time. So information was provided regarding glutaminyl acetate and the beta interferons. So as far as treatment options, IV steroids were administered for 3 days. A return visit 2 weeks after the initial consultation was scheduled with a nurse practitioner in the clinic. On the return visit, the patient had moderately improved visual acuity in the right eye, measured at 20/40. Although the patient was willing to discuss preventative therapies, she wished to know more about the possible oral medications for MS. The patient was also admitted to symptoms of anxiety and depression predating the diagnosis, but they were clearly worsened since the previous appointment. The role of steroids in her insomnia and nervousness was addressed. However, the patient was tearful throughout the whole appointment, despite the clear support of her spouse. No medications were prescribed for these symptoms at this time. She was also alarmed about the potential flu-like side effects, especially when given her significant deadline stresses at work that she had to deal with, and the care of her 2 children, 4 and 7. The nurse practitioner reviewed the risks of delayed treatment in light of the CIS trials with numerous preventative agents, and reassurance was given that the initiation of an injectable first-line medication would not prevent the use of an oral agent at a later time. Given the issues regarding tolerability, an agreement was made at this visit to initiate glutaminyl acetate and to follow up again within a few weeks of starting therapy. So, continuing it, treatment with glutaminyl acetate was initiated approximately 3 weeks later. The scheduled follow-up appointment with the doctor occurred 3 weeks actually after that. So, adherence to the medication actually was pretty good, but the patient admitted that she was prodded daily by her husband to take her medicine. He occasionally performed the injections for her. The anxiety and the depression symptoms were even worse than on the previous visit, and an SSRI was prescribed, although the patient was not certain she'd actually take it, saying that she felt overwhelmed at this point by the medications. Telephone contact. The patient called the nurse practitioner 2 weeks later and reported difficulty with injection site reactions, and after discussion, the NP discovered that the patient was injecting her inner thighs and the belt line at the waist, several areas that were really outside of the recommended sites. So retraining was requested. We had a visiting nurse successfully visited the patient with retraining, successfully in reducing the severity of the injection site reactions. On a follow-up phone call, the patient stated that she had started the SSRI and was experiencing positive results. So this is actually a scenario that we see all the time, you know, and that we deal with. And this is where the follow-ups come into play. And this is where where all the assessments that we need when we're discussing with the patient are very, very important. I think especially when a patient is starting a new therapy, follow-up within a couple weeks is almost essential to make sure that if there are any issues, we need to take care of them right then and there. So in conclusion, adherence to medicines is definitely an important aspect of patient care. Non-adherence, we know, is widespread, and it does impact our health outcomes. Should be done at each visit, And we need to identify that each patient, just as their MS is so individualized for them, that each patient has individual barriers, and we need to identify and address them, and specific questions and strategies we could actually use within discussion.